Good day. Welcome to Coronary to Abstract session. I am Kyoo-Rok from Korea. My co-chair is Dr. Linda Lison from Indonesia. And today we have two panelists, Dr. Azfar Hossain Bhuiyan from Bangladesh and Dr. William Kongto from Hong Kong. Today we have 5 topics and 5 speakers can present 5 topics. Let me start the first topic. The first speaker is Dr. Kenji Sadamatsu from Japan. The topic is pre-dilation with a scoring balloon on small side branch occlusion during long coronary stent implantation. Dr. Sadamatsu, please.
I'd like to talk about the prevention of side branch occlusion by a scoring balloon. I don't have no COI. Recently, longer coronary stents are available, and the use of PCI in the treatment of long coronary lesions has been expanded. Generally, the longer a coronary lesion is, the more septal branches it has. So we often have to face the issue of small side branch occlusion in the treatment, because we could not protect all branches originating from the long lesion. Scoring balloon catheters are designed for use in focused force angioplasty, and stress to the plug are concentrated in the scoring element, and then expected to gain a larger lumen with a lower inflation pressure. The lower inflation pressure and controlled plug fracture by scoring balloons might prevent deep and major dissection, and thus lead to avoid the side branch occlusion. In this study, we investigated whether pre-dilation with the scoring balloon catheter prevent the side branch occlusion during the long over 30 mm stent implantation. So we retrospectively corrected consecutive patients who underwent PCI using at least one long over 30 mm coronary stent and divided it into 2 groups. SC group is a pre-dilation with a scoring balloon, 47 patients with 50 lesions. CV group is a pre-dilation with a conventional balloon, 57 patients with 59 lesions. The flow injury after stenting was assessed in all visible side branches originating from the stented lesion. The side branches, though some protection technique was applied, were excluded. So most of the included side branches were small branches, smaller than 2 mm in diameter. The number of included side branches were decided based on the power correction. Result: this is the patient characteristics. That's no difference. Most of the diagnosis was a chronic coronary syndrome. This is procedural characteristics. Most of the cases underwent with 6 French radial approach. Cultured lesion was higher in the scoring balloon group, and wire protection was used in half of cases. Balloon diameter was not different, and inflation pressure was tended to be lower in the scoring balloon group. Total stent length was 40 mm. This is a key slide. The percentage of side branch injury after the stent deployment and the side branch occlusion at the final shot was significantly lower in the scoring balloon group, about 45% reduction. So mean diameters of injured side branches was not different between the scoring balloon group and the conventional balloon group, about 1.1 mm. The percentage of periprocedural myocardial injury was significantly higher in patients with side branch injury than patients without side branch injury. Discussion. Periprocedural myocardial infarction and myocardial injury in elective coronary stenting are associated with cardiovascular events and ischemic events. And the previous reports about small side branch occlusion are limited. So the occlusion rate in your report, in your study, was comparable to the previous reports. There are some limitations in our study. A small number and single institution and retrospective analysis. And the selection of balloon catheters were left to operators' decision, mostly preference. It was difficult to assess detailed characteristics of side branches because some bifurcations are not clearly visualized, especially in small branches. And small branches, small arteries are not analyzed with the QCA software. The mechanisms of side branch occlusion were not investigated with intracoronary imaging modality. In conclusion, lesion preparation with a squaring balloon was associated with the lower occlusion rate of side branches after long stent deployment than conventional balloon. This simple technique is feasible and useful in the treatment of complex coronary lesions with a long stent. Thank you.
Thank you, Dr. Sadamatsu. First of all, I'd like to invite some comment question from panelists. Is there any question?
Okay, may I start? Okay,
yes,
this is
sure.
Dr. William from Hong Kong. Dr. Sadamatsu, so in your study, you didn't use any invasive imaging, right? No OCT or IFS before the stent implantation, before the scoring balloon?
We conducted IVAS or OCT in all cases, but unfortunately, we did not assess the risk of side branch occlusion in each case.
Okay.
So,
but my question is because if you do invasive imaging, and I'll expect you're going to assess, the part burden and the tissue morphology, right? And I believe the tissue morphology and the part burden is going to affect your result.
Yes, I agree on that. Intracoronary imaging modalities is very useful to estimate the risk of side branch occlusion. But in longer coronary lesions, the long lesion has many side branches, so it is difficult to estimate each risk of side branch occlusion. Only use of squaring balloon catheter is useful to avoid side branch occlusions. It's easy and
okay. So how you choose your balloon size? Using the IFS, OCT, or based on the QCA?
Based on IVAS data, I decided that balloon size and stent size.
Okay.
Thank you.
Dr. Sadamatsu.
Yes.
What is your criteria for pre-dilation side branch?
Of course, for the side branch protection, it is useful method to side branch dilation. But in this case, side branch is small, so it is we did not pre-dilate the side branch with balloon.
I think you do not pre-dilate all the side branches.
Yes.
So for what reason? For what side branch do you do the pre-dilation?
Of course, for the significant side branches, I prefer to use some techniques like modified gelled balloon techniques. So in this study, protected side branches like using pre-dilation is excluded from the analysis.
Okay, any other question, comment?
Yeah, Dr. Sadamatsu,
Yes.
what type of lesion did you used scored balloon? Any calcified lesion or every you used in calcified lesion?
Thank you. In this study, I demonstrate the usefulness of scarring balloon for the bifurcation region. In the previous studies, I also demonstrate the usefulness, effectiveness of pre-dilation of size scarring balloon catheter for drug-eluting stent implantation. So actually, I use scarring balloon in most of the cases, not only calcified region.
Okay, thank you, Dr. Sadamatsu. Let's move to second topic. Dr. Lison, please.
Yes, for the second presentation from Korea, Dae Young-hoon, he will talk about proper application time and effect of extracorporeal membrane oxygenation in the patient who under PCI for acute MI with the cardiogenic shock. Please, Dr. Hoon.
Thank you for the great opportunity to present this study. I'm Dae Hyun from Jeonnam National University Hospital. I declared no potential conflict of interest related to this article. AMI complicated by cardiogenic shock classified as a very high-risk group is a medical emergency situation that requires immediate invasive therapeutic strategy. Although early revascularization of cochlear lesion in coronary artery induces significant survival gain, there are still many cases that cardiogenic shock has not been resolved. The application of ECMO can be considered in patients with AMI complicated by cardiogenic shock who are not improved by medical treatment or IVP. In this study, only ECMO-assisted primary PCI was improved compared with conventional primary PCI in patients with STEMI complicated profound cardiogenic shock. Early ECMO-assisted primary PCI group showed in lower mortality rate than conventional primary PCI group in 30-day follow-up. However, there are still limited data about application time and long-term clinical outcome in ECMO. Therefore, this study evaluates the 3-year clinical outcome of patients with the AMI complicated cardiogenic shock according to the application and initiation time of ECMO. This study was based on CAMI-NIH, which is a nationwide prospective observation multicenter registration. Among these patients with AMI, results CAMI-NIH from 2011 to 2015, 1,001 patients with cardiogenic shock who underwent successful PCI were included to the study. Exclusion criteria were no cardiogenic shock, no PCI, suboptimal and failed PCI, ECMO application before CPR. Study population were divided into 2 groups depending on the use of ECMO. No ECMO application group, ECMO application group. The ECMO application group was divided into 2 groups again, ECMO application after CPR, ECMO application without CPR. Although the ECMO application group was younger than the no ECMO application group, they had more Killiquence over 3, lower blood pressure, and LV ejection fraction. In addition, the ECMO application group showed higher myocardial enzyme level in blood test and took medicines such as ACE inhibitor or ARB beta blocker and statin less. When compare the ECMO application without CPR group and the ECMO application after CPR group, they were almost similar. But the ECMO application without CPR group had more diabetes mellitus. The proportion of patients with the left main coronary artery as a culprit vessel was higher in ECMO application group than the no ECMO application group. The ECMO application group received the bare metal stent and IABP more frequently than no ECMO application group, where IBUS guided PCI was less done in ECMO application group. In hospital complications such as acute heart failure, ICH, hemoglobin decrease, hematocrit decrease, CPR, multi-organ failure, defibrillation, and AKI were more common in the ECMO application group. When compare the ECMO application without CPR group and the ECMO application after CPR group, they were almost similar in procedure finding and development of in-hospital complication. At 3 years, the ECMO application group had a higher risk of MACE than the no ECMO application group. The risk of all-cause death was also significantly higher in the ECMO application group. When compare the ECMO application without CPR group and the ECMO application after CPR group, the risk of MACE was lower in the ECMO application without CPR group. The rate of all-cause death was also significantly lower in the ECMO application without CPR group. When compare the ECMO application without CPR group and no ECMO application group at 2 years, there were no significant difference in clinical outcome. However, the risk of cardiac death and all-cause death or MI were significantly higher in the ECMO application without CPR group at 3 years. This is a figure of the table contents. ECMO application without CPR showed a significantly lower risk of MACE and all-cause death compared with the ECMO after CPR in patients with AMI complicated by cardiogenic shock. And the ECMO application without CPR showed similar outcome of MACE and all-cause death compared with no ECMO. In this present study, 7.6% complicated by cardiogenic shock underwent successful PCI among 13,000 patients with AMI. ECMO application was done in 11% of enrolled patients complicated by cardiogenic shock, and only 9% of patients among them were applied with ECMO without CPR. So far, ECMO has been used as the last remedy for rescue, and it has not been used frequently before patient condition got worse. In this study, ECMO before CPR showed a good long-term clinical outcome. So early application of ECMO can be considered as a reasonable procedure strategy in patients with cardiogenic shock with AMI to improve the clinical outcome. Thank you for your attention.
Any comment and question from the second topic?
Okay, Dr. Yang, I got a question because in your patient group, the ECMO without CPR, you only got 10 patients, and the number is really small. So how can you draw conclusion just based on that 10 patients?
In this study, only 10 patients underwent ECMO without CPR.
Yes.
So small patient, but this showed in clinical situation using the ECMO in Korea. So, so more large scaled study should be done to more see the correct right answer, to see the right answer.
Oh, okay, yeah, I understand. Sometimes very difficult to get, I mean, a large number of patients. And then the other thing is that in your presentation, I see that you are using some bare metal stent, right? Is it because this is in the early stage? Because your study started in year 2011. So I expect in the early days, you're using more bare metal stent. And then in the later day of the study, you're using more DES. Is that correct?
Yeah. Bare metal stent was more frequently used in ECMO patient, and hence I reviewed the data. TS more frequently used after the ECMO.
Okay, I'm just curious. Why is that? Okay, so what is the reason you're using more BMS for the ECMO patients?
ECMO patient?
Yeah, you're using more BMS, right?
Because of we think short DAPT can be used in PMS, so ECMO group were more used PMS.
Okay, understand.
Okay, as we know that the patient without CPR, maybe the patient is not in a severe acute MI, so the survivor is not so serious than the patient in CPR. Have you checked the functional test for the patient after that?
Functional test, like?
Yeah.
Functional class.
Functional class?
Yes, functional test. Like the MRI or nuclear study.
Yes, MRI and like MSPECT was also listed in this study, but I did not show the result. I will review that data.
Okay.
Dr. Hyun, I think your data is from the camera data, is right?
Yes.
Actually, the camera data collected more than 10 years ago. So the situation different from in these days.
Yeah.
Maybe that would be the one reason.
Yeah. It will be interesting to show the trend of ECMO in Korea. So I will more study about the trend of Korea using the camera data.
Okay, thank you, Dr. Hyun.
Yeah, I have a question to Dr. Yang.
Yeah.
All of your cardiogenic patient was before procedure or during procedure? Any patient went cardiogenic shock or CPR needed during the procedure or before the procedure?
All patient was enrolled who underwent a successful PCI with cardiogenic shock. ECMO patient all were enrolled before and after during the PCI.
And you used ECMO during the procedure, or that's after balloon failed?
Dr. Bhuiyan, actually, this data is from the Camille study for collecting more than 10 years of acute myocardial infarction. So from the beginning, I think that data is not included in this data.
Yes, ECMO was not included in the early Camille data.
From my personal point of interest, I want to know how many ECMOs are available in your institution.
In our case lab?
Yeah, no, in your institution or in your hospital.
In your hospital.
Yeah. Because we don't have any ECMO in our country.
We more frequently use ECMO, 5 to 10 ECMO apply per month. About
the number of ECMO available in your hospital, how many?
Number about four ECMO can be used.
Okay. Thank you.
Okay, thank you, Dr. Hyun.
Yeah, thank you.
Let's move to the next topic. The next topic is urinary alpha microglobulin as a novel predictor for in-hospital all-cause mortality in patients with ST segment elevation, myocardial infarction. The speaker is Dr. Hehe from China. Dr. Zui, please.
Yeah, good afternoon, Professor Han, Professor Lison, Professor Bhuiyan, and Professor Hao. Ladies and gentlemen, I'm Hehe Cui. On behalf of Professor Chen Hui and Professor Li Hongwei and the investigators of China Beijing Friendship Hospital Database Study, it is a great pleasure to share the results of our study regarding to the prognostic value of urinary alpha-1 microglobulin in patients with ST elevation myocardial infarction at TCTAP 2021 conference. Now, these are my disclosures. Alpha-1 microglobulin, now we call it A1mg for short. Now, this is a highly conserved small molecular weight glycoprotein. It is 26 kilodalton, and it is synthesized in the liver and broadly distributed in the serum, monocytes, heart, liver, gut, and so on. And finally, it is excreted from the kidneys. Few studies in cardiovascular field have investigated the role of UA1mg. A study published in 2006 reported that urinary excretion of A1mg in patients with myocardial infarction significantly elevated, and the levels of UA1mg were positively correlated with higher plasma levels of C-reactive protein and troponin I. Recently, Professor Hakuno firstly demonstrated A1mg induced cardiac toxicity, but this study is in the mouse myocardial infarction model. They found that A1mg distributed in the infarct and the border zone during acute phase, reflecting the infiltration of macrophages. Intramyocardial A1mg administration exacerbated macrophage infiltration, inflammation in the infarct sites and the border zones, and this disturbed fibrotic repair. Besides, a subgroup study of the SPRINT study revealed UA1mg was associated with cardiovascular events and mortality among non-diabetic persons with chronic kidney disease. Now we can see the hazard ratio of UA1mg is the highest among these kidney biomarkers. However, above studies have their limitations. For example, small sample size, and the study population when unrepresentative was not classified into STEMI or non-ST elevated acute coronary syndrome, and restricted to CKD or lack of investigation into prognosis. Now, based on about knowledge, we proposed our study hypothesis that admission UA1mg value predicted in-hospital prognosis in STEMI patients. The protocol was approved by ethical committee, and more than 2,000 consecutive patients from 2013 to 19 with acute STEMI were evaluated retrospectively. The data was collected from database. And it should be noticed that the UAMG was tested using the overnight clean midstream urine, which was sampled in the morning during hospitalization within 24 hours. And the clinical endpoints is in-hospital mortality, cardiac death, major adverse cardiac events. Now, this is the flowchart of the study. Should be noticed that we rolled out some active infection, hepatic biliary diseases, and end-stage renal diseases. Finally, based on the tertiles of the baseline UA1-MG value, we classified the final population into 3 groups. This is the basic characteristics of the patient. We can see that some factors such as age, male, were different among the tertile groups. And as to the laboratory indexes, there are some differences such as white blood cells, neutrophils, hemoglobin, and high sensitive CRP among the tertile groups. Now we can see we found that the high UA1-MG group have elevated peak value of CKMB, troponin I, and NT-proBNP. And also patients have significantly reduced left ventricular ejection fraction. And correspondingly, patients had significantly higher in-hospital mortality, more cardiac deaths and MACEs in the high UA1-MG group compared to the low UA1-MG group. Now we make the logistic regression analysis. We included 10 factors into multivariate logistic regression analysis. And after the adjustment, we found that UA1-MG remained independent in hospital mortality. The odds ratio is 1.109, and the p-value is 0.008. Now, we made ROC analysis of UA1-MG value, and we find that the area under the curve is 0.73, and this is statistically significant. And to find the possible reasons for the predictive value in UA1-MG, we performed Spearman correlation analysis, and a correlation between UA1-MG and high sensitive CRP, as well as a correlation between UA1-MG and creatinine were demonstrated. Now, there are some limitations of our study. First, UA1-MG as a urinary biomarker for monitoring the cause or the prognosis of STEMI. It is easy and convenient to acquire because avoid venipuncture. However, the shortcoming is it is affected by renal function, no matter glomerular function or the tubular function. And due to this is a retrospective study, the blood test result of A1-MG was not performed simultaneously. So we cannot monitor it with a comparison. Besides this, because the storage nature of the bladder, the urinary indexes always showed a delayed alteration than blood test result. Although our study proved a relationship between UA1-MG and cardiovascular endpoints. However, the role of A1-MG remains unrevealed. Is it an antioxidant molecular or a pathogenic factor or merely a biomarker? I think the future study will confirm that. Now we draw the conclusion that UA1-MG value at hospital admission independently predicting hospital mortality among patients diagnosed with STEMI. And it is probably because UA1-MG indicates the presence of renal function and inflammation. This is my study. Thank you. Thank you all.
Thank you, Dr. Cui. Thank you for your excellent study and excellent presentations. Any comment and questions?
Okay, Dr. Cui, I got a couple questions. In your study, I see that you exclude 67 end-stage renal function patients. However, in the study, you didn't really tell us, what are the renal functions of the patients. So it's very difficult to say, whether it's a renal function of the patient affecting your result or not. So can you comment on that?
Thank you for your question. You mean the renal function? Yes, this is a very good problem. So in the beginning of the study, we rolled out the end-stage renal diseases. That means the eGFR less than 45, because I think this renal function might influence the content of the urine. So this the patients with heavy renal disease was ruled out. However, in the study process, we also analyzed the level of creatinine. We can see that in the higher tertile and maybe with the higher creatinine level. So I think the renal function also influence the results. Also, we know renal function is an unavoidable factor in all the risk models, such as GRACE, such as CRUSADE, and so on. The renal function cannot be ruled out. So we do the correlation analysis in the end, and we find there must be a correlation between UA1mg and the creatinine level. So we do in the multivariate analysis. We did not include the creatinine level inside, because we think if we include this factor in the multivariate regression analysis, maybe the result may be not may be influenced with each other. Yeah. I don't know if I make a clear explanation about the question.
Okay, so this is a retrospective study, right?
Yeah, retrospective
okay,
study.
So I guess now when you did this study and during that time, you didn't really assess the renal function at all, right? So, but I feel it would be interesting, if you look into the renal function. I mean, in the future, if you're going to have a prospective study, I think you can look into the renal function and try to see whether it's going to affect your UAI-MG as well.
Yeah. Thank you.
Any other question, comment?
Yeah, I have a question. Is there any correlation between the level of UA1mg and extension of MI, severity of MI?
So we did not explain this question in this study, but we find that UA1mg level is correlated to some extent with the myocardial injury biomarkers such as cardiac troponin I and CKMB. So I don't know whether the elevated UA1mg will induce extension of myocardial infarction. So, but this is the observational study showed a trend. So maybe the question will be illustrated by future study.
Okay, thank you.
Thank you.
Dr. G, as you know, alpha-1 microglobulin is a protein related to oxidation and inflammation. So the high level of microglobulin means large infarction. So what do you think is the additional value of alpha microglobulin over cardiac enzyme? What is the additional value?
I think the additional value is because UA1mg is urinary, can be monitored in urine. It is a urinary biomarker. So it is easy and convenient to acquire. So maybe this index might provide some additional values to monitoring rather than diagnosis of the disease course. So if maybe the consistent elevation of UA1mg maybe implicates more terrible or more heavy disease.
So you mean the most valuable, the most interesting value of this microglobulin is it is easy to monitoring.
Yeah, it is easy to monitoring. Yeah.
Okay.
Thank you.
Any other question, comment?
Is it? I have a question. Is it cheaper than to do troponin I?
No, I don't think so. That is because
what's the implication of doing this?
Yeah, because because troponin I or CKMB is well acknowledged by across the world. So I think we make this study just to provide some additional value of monitoring the disease. We do not want to replace the value of troponin I. Yeah.
Okay, thank you.
Okay, thank you, Dr. Chui. Let's move to next topic. Dr. Lison, please.
Yes, the next topic we present by Bhuiyan. He will talk about the transradial versus transfemoral access in STEMI patient under rescue PCI post-fibrillary therapy, a 10 years contemporary national center. Please, Dr. Kwa.
Very good afternoon to all the panelists, judges, and my fellow colleagues. My name is Bhuiyan, and I'm from the National Heart Institute of Malaysia. And my topic today will be the transradial versus transfemoral access in STEMI patients undergoing rescue PCI, post-fibrinolytic therapy, a 10-year contemporary national center experience. So thank you very much for this opportunity. I'm very humbled to be able to present my study. I have no conflicts of interest. So a bit of background first before we go into the study. PCI is, we are all well aware, is superior to fibrinolysis in patients with STEMI. And however, fibrinolytic therapy is still widely used in Malaysia for many factors, logistic issues, cost issues, and even resources. And therefore, rescue PCI plays a crucial role in STEMI management, especially in our setting. Rescue PCI is not addressed specifically in a lot of studies before this. A lot of previous studies that assess vascular access, like the RIFLE study, the MATRIX study, and even these studies actually group rescue PCIs with primary PCIs. So it would be very worthwhile to look into these subgroups. Vascular access is therefore a major concern when we deal with rescue PCI. And based on the latest ESC guidelines and the ACC AHA guidelines, they actually recommend radial access to femoral access to reduce complications. So the objective of this study is to assess the safety and clinical outcome of radial versus femoral access, the trend of usage, and the characteristics of patients. This is a retrospective observational study. We managed to get 498 patients with acute STEMI that underwent rescue PCI in the National Heart Institute from January 2007 to December 2016. And we analyzed the demographics, the risk factors, and the procedural characteristics as well. And we analyzed the yearly trend. We also compared the outcomes between both approaches, and we look at the MACE events and even in-hospital mortality rates. So let's go into the results of the study. Initially, we managed to, among these 498 patients, 59% of them actually were under the femoral group, while 41% were using radial access. And as we look at observe the trend of usage over this decade-long study, we noticed that initially highlighted in yellow is the femoral access. It was the predominant vascular access until 2014, whereby it was overtaken by the radial access highlighted in blue. So now look into the baseline demographics and clinical characteristics. Both groups, the age, mean age was roughly similar. And the age range, not significant per se statistically, but almost 0.028. We noticed that there were more patients, more elderly patients in the femoral vascular group. And further analysis of the results, you can see first was the kidney function, as highlighted in the orange box. The patients in the femoral group, femoral access group, they tend to have worse off kidney function, which was statistically significant. Patients tend to be more ill. They have history of myocardial infarction, history of heart failure, history of chronic renal failure. And their KILIP classes, when they presented to us, tend to be much higher than the radio access group. And they have significantly more usage of intra-aortic balloon pumps. So you're looking at the hospital outcomes, we can see that there was statistically significant better outcome in the radial group compared to the femoral group, while there was no difference in terms of bleeding outcome. When we follow up these patients up to a year, we can see that especially MACE, there was no difference in terms of MACE and follow-up outcome in both groups. And this is the Kaplan-Meier survival graph, which again illustrates my point, which they have no statistically significant difference between both vascular accesses. So discussion points. The usage trend over the past decade seemed likely, as you can see from 2014 onwards, that it was overtaken by radial access, seemed likely due to the landmark studies for benefits of radial over femoral access in terms of lower bleeding rates and so forth, improving skills and even experience of operators in my center. So from this study, we can then infer that radial approach confers more favorable outcome in terms of in-hospital mortality. And this can be explained likely because the group of patients in this femoral access, using this femoral approach, were more ill at presentation and had more comorbidities, and therefore tend to succumb to more morbidity, higher morbidity and higher mortality. And then, of course, we can see that there was no difference in both arms when we talk about follow-up outcome and MACE events. Limitation of my study, it's not a prospective randomized control trial. There's a limited number of patients, it's a single center, and of course, we didn't look into the experience of respective operators as to which operators were actually conducting each angiogram. So my conclusion and take-home message from this, the result in this study was somewhat similar with the recent Safari STEMI trial, which there was no significant difference between the MACE events and MACE outcome or even bleeding events between radial and femoral access. Taking into account that this Safari STEMI study was actually terminated earlier because they due to futility analysis saying that there was no difference in events. So in this new era with COVID-19 pandemic, I think there's a continuous debate as to whether primary PCI should be deferred with thrombolysis first approach being adopted in many places. And therefore, I think this study is pertinent because operators can be assured of the similar bleeding events, and that operators who use or approach or adopt a femoral approach in rescue PCIs, especially in this pandemic area, they can be reassured of the similar bleeding events and MACE events compared to radial approach. So in conclusion, radial approach should be attempted as long as it's feasible, while operators need to be very proficient in the femoral approach, especially in time-critical procedures such as rescue PCI. Thank you very much.
Thank you, Dr. Jin. Any comment, question?
Okay, Dr. Jin, this is an interesting study. So in your study, it actually shows us that in the femoral approach group, the patients are more sick.
Yes.
But I'm just wondering, so in the first place, when the patient admitted to IJN, so how you decide the patient should go for radial approach or femoral approach?
It's a good question, sir. So like this is a retrospective study. So I mean, ideally in a prospective study, we would randomize such patients. Although some people consider it a bit unethical, I mean, when they conducted the Safari STEMI study as well. But in our case, based on this retrospective study, it was based on the preference and the experience of the respective operators that chose either they choose radial or femoral access.
Okay, so it's not because the patient is more sick, right?
Actually, yeah, because but it's actually a good you would tend to prefer a femoral approach if the patient is more ill.
Okay.
by this study because they want to insert an intra-aortic balloon pump as well. And most operators in my center from this study seem to be more comfortable with femoral approach, especially if the patient is ill.
Okay, and then the other question is that because Malaysia is a big country, and I know in Sabah and Kuching, they're doing more thrombolysis, right?
Yeah.
Because it's a huge area, and they only got 1 or 2 hospitals. So it's impossible to do primary PCI for all the patients.
Yes.
So are you comparing the data from Sabah and Kuching to KL, like IJN? I think the data will be very interesting,
Thank you, Dr. Hao. You seem to be very familiar with our logistics here.
Yes, because I know Adam Fong, I know Hong Bang really well.
Yeah. So the good thing is I've worked in Sarawak before for 2 years. I know Dr. Alan Fong and also Om Babik in Sabah. So I've worked in Sarawak, and to let you know, if you are staying in Sarawak and Sabah, you are in rural areas. So it's almost impossible to do a primary PCI. You have to travel by helicopter, you have to travel by bus, by ambulance. Ambulance takes about 12 hours. It's just not practical at all. So in Malaysia, even in Peninsular Malaysia, KL and northern states to southern states, all of us practice fibrinolysis. Very few centers in Malaysia, unfortunately, practice primary PCI because of the resources and because our network is not fully established, the cost and logistics. So yes, it can extrapolate it actually to Sabah and Sarawak in terms of rescue PCI, because we do send patients. I worked in Miri Hospital before. It's about 12 hours journey from Kuching, from Dr. Alan Fong Center. So if we have patients who fail fibrinolysis, we have no choice. We have to send them by helicopter. And the helicopter had to stop halfway and to refill the petrol tank, before they can go on another journey. So patient will definitely be delayed. But we do try to offer our best to the patients in that sense. But yes, fibrinolysis is still the primary mode of VIVAS in Malaysia. And rescue PCI is very, I would say, very crucial role in here.
Yeah, Dr. Wijin, I have a question. Have you switched over from radial to femoral in this study? Any patient who is lack of guide catheter support or due to anomalous origin of coronary arteries?
Yeah, unfortunately, I do apologize. My study didn't address that. I think it will be good to see those patients who actually attempted radial and then switch over to femoral because of failure or complications. But unfortunately, I wasn't able to look into that specific element. But I'll try to look into that for future studies.
Okay, thank you.
Dr. Jin?
Yes, sir.
Recently, we have many data about the lower mortality rate with the radial approach other than the femoral approach after PCI. We think the main reason is the radial approach can reduce the bleeding outcome, the bleeding complication. But in your data, the radial approach can reduce the in-hospital mortality, but the bleeding outcome is similar.
Yes.
So what is your explanation? Why the radial approach can reduce the in-hospital mortality?
Yeah, so my study actually shown that the patients in this femoral access group were more ill. They had more comorbids. They came in with KILIP class 3, class 4. They were in cardiogenic shock. So they were more ill to begin with, probably had more severe lesions. Perhaps that's what contributed to the better in-hospital mortality for the radial approach, rather than the bleeding events contributing a significant part, because the bleeding events were similar. No statistical significance difference.
So I mean, your data have some bias.
Yeah, because patients were more ill in the femoral group.
Okay.
I guess perhaps that's why they had worse off mortality.
Okay, thank you, Dr. Jin.
Thank you very much.
Let's move to the final topic. Dr. Lison, please.
Yes. Yes, the final topic is the presenter will be Tian Yu Li. She will talk about the effect of age and the sex on outcome of after PCI or CABG in non-STEMI patient with the triple facial disease? Dr. Lee, please.
Thank you. Thank you very much for introduction, Dr. Linda Lison. Good afternoon. My name is Tianyu Li, and I'm from Bhuiyan Hospital, Beijing, China. It's my honor to have the chance to share our work. The topic of my presentation is effects of age and sex on outcomes after PCI versus CABG in non-state ASS patients with 3-vessel coronary artery disease. There is no conflict of interest to disclose. First, some background information about this study. The 2020 ESC guidelines for non-state ASS recommended that criteria applied in stable CAD patients to guide the choice of revascularization strategy should also be applied to non-state ASS patients. This indirect recommendation reflects that evidence is limited to support one revascularization strategy over the other in non-state ASS patients, especially for those with TVD. Besides, age and sex are important considerations in the choice between PCI and CABG in daily clinical practice. But elder patients and women are often underrepresented in RCTs. Whether and how age and sex modify the comparative effectiveness of PCI and CABG is unclear. Thus, we aimed to add evidence by conducting a post-hoc analysis of data from our real-world prospective cohort of nearly 10,000 patients with TVD. Here is the study flowchart. A total of 2,812 patients were included, in which 22.8% were women. The median follow-up time is 6.7 years. The primary endpoint was MACE, consisting of all-cause death, myocardial infarction, and stroke. Let's move on to the results part. In the entire population, CABG was associated with significantly lower MACE rate than PCI. Then we divided the study population into 3 age groups. Under age 65 to 74, over age 75. Consistent with the result in the entire study population, cumulative incidences of MACE were significantly lower after CABG than that after PCI in the 2 younger age groups. In the group of over age 75, the benefits of CABG did not exist. We also divided the study population into 2 sex groups. Cumulative incidence of MACE was significantly lower after CABG than after PCI in men, but not in women. Interestingly, we didn't observe treatment by subgroup interaction according to age or sex. So we further analyzed the interaction between age and outcomes after revascularization in each sex group to explore whether there is a sex-based difference in the effect of age on the benefit of CABG relative to PCI. Meanwhile, we also analyzed the interaction between sex and outcomes after revascularization in each age group to explore whether there is an age-based difference. We found that for women over age 75, the risk of MACE after CABG was 3 times higher than after PCI. The difference was driven by the increase in mortality after CABG, not MI or stroke. The interaction P with sex in the group over age 75 and the interaction P with age in women were both significant. Sensitivity analysis yielded similar results. Now we come to the take-home messages of this study. CABG is superior to PCI in most non-status patients with TVD, as it results in significantly lower MACE rate. Women over 70 years of age undergoing CABG experienced a significantly higher risk of MACE, mainly due to the increase of all-cause death. That's all for my presentation. If you have any questions, please feel free to ask. Thank you.
Any question, comment?
Okay, I think this is an interesting study. Okay, but honestly, when I think about the study, because for female, usually, for female patients, usually they're older, and also, usually, they're more classification, right? So, in your study, did you look into the Stent score? I'm just curious because I'll explain. For those patients that are older than 75, especially in the female group, the Stent score is going to be higher.
Yes, we included the syntax score. Wait a minute, check the data.
So for those patients that are older than 75, the syntax score is higher, right?
The syntax score is comparative in among these groups.
Okay, so if
the p-value is not significant.
Okay, so if that's the case, so can you explain why for those patients, especially the females, if they're older than 75, CABG is not going to help? It seems that over 75 PSI is better in a way. Right?
The significantly higher risks of CABG relative to PCI for MACE and all-cause death should be regarded as a hypothesis, I think, and that should be investigated in the future study. We did an IPTW analysis and PS score adjusting Cork's regression method and used E-value to assess potential of unmeasured confounding, and all this sensitivity analysis showed similar results. So I think it's a very interesting thing, and maybe. But yeah, maybe it needs future study.
Okay.
I think.
So think about that. Let's say you have a patient, she is over 75 years old. So we will recommend her to go for PCI or CABG based on your data. So let's say you have a patient coming to you. She is a female, okay, and she's over 75 years old.
Yes.
So should she go for PCI or CABG based on your data?
I think the data suggest suggest PCI superior to CABG, but I think in clinical practice, it should depend on the patient's clinical status and other characteristics. So I think this data cannot draw a very clear conclusion since it's a retrospective study.
Okay, I'm not giving you a hard time, but just because you have a really interesting finding.
Yeah.
Yeah, so you mean you have to customize all your patients. Okay, right. Any other question, comment?
Yeah, Dr. Lee, can you say what is the cause of significant MACE in aged people? Is there any significant causes? I want to know the cause, which for which it is significant in significance of MACE in aged older women.
All-cause death.
You told that over 75 years of women, there is significance of MACE. Can you tell what is the cause?
I'm sorry, I'm not thinking about this, and I think maybe this one is
procedural problem or anything else.
I think maybe in elder patients, the potential protective factors of women do not exist. And also because of the poor tolerance and poor social support of women to surgery.
All right. The time allotted to us is 60 minutes, and we use all the time now. So let me say hello to all the people. Thank you for Dr. Lison, and thank you, Dr. Bhuiyan, and thank you, Dr. Hao, and thank you all the speakers. Let me conclude this session. Thank you.
Thank you, Kyoo-Rok. Thanks.
Thank you. See you. See you next
See
time.
you.
See you.
See you.
Bye.
Thank you, everyone.
Okay. Bye.
Bye.